Who stole my name? Oh, all seem traumatized after that one. They're all looking at me like, oh my God. So today we're going to be talking about the respiratory system. Okay, we're going to do Kahoot with it. Our skills lab this afternoon from 1 to 3. Tanessa will be going over some stuff. I'm going to be going over some pediatric related stuff. Okay. Tomorrow, we won't have traditional lecture. I will have it voiced over. I'm going to try to have it up by this evening, but it's probably not going to be up until tomorrow afternoon, which is fine. Because what we're going to do in class is you don't have to have listened to the lecture to be able to do it. Okay. So class tomorrow will be interactive. Okay. You do need your textbook tomorrow. And if like one of you want at your table says, I'll bring the med surge, and the other one wants to say, I'll bring the maternal child, y'all can do that. So that way both of you aren't having to bring 2 textbooks. Okay. Because you need both tomorrow. Okay. Everybody logged in that wants to play.
Oh, you're back.
Cool. If the numbers keep going down like they have been, we're talking about maybe discontinuing masks as of next week, maybe. Okay. One website said one thing, one website said another thing, but I'm pretty sure they are coming down. I know our hospitalizations are down. So we're looking at, since everyone in here haven't had any phone calls of exposures or anything in a couple weeks now, we may discontinue masks again. But don't stop until I tell you. Okay. Judy and I are just watching this week to see how the numbers stay. Okay.
I was really surprised when I worked this weekend. I was really surprised.
Yeah, y'all weren't busy. I was busy.
Yeah, I heard. I heard.
I was really busy. I worked nights this weekend and it was crazy. Okay, let's get started. So we are looking at the respiratory system. So this is mainly chapter 25, chapter 26, 27, 28 in your med surg book talks about different disorders of the respiratory system. I did pull a few diagnostic testing things out of those chapters, okay? But the majority of this content is coming out of chapter 25, okay? So the primary purpose of the respiratory system, you know, is gas exchange, okay? We're bringing in oxygen to supply our body. We're blowing out CO2 that we don't need, okay? While adequate perfusion is needed to distribute this oxygen to the body tissues, adequate oxygenation depends on the healthy functioning respiratory system. Okay, so we need the heart to pump it, but if the respiratory system is not healthy and able to absorb the O2, then even though we're pumping it, it's not going to be sufficient if it's not taking in enough oxygen. The upper respiratory tract includes the nose, the mouth, the pharynx, the epiglottis, the larynx, and trachea. Okay, you guys learned this in anatomy. Air enters the respiratory tract through the nose. Once the air passes the carina into the lower respiratory tract, the lower respiratory tract consists of the bronchi, the bronchioles, the alveolar sacs, and the alveoli. So we have an upper and a lower respiratory system. Both have to function for you to have air go in, okay? Your upper respiratory functions, but your lower's not, no good. Your lower's functioning, but you have trauma or blockage in the upper, no good, okay? So instead of going through and having to do this review with you, I got a really neat video over, if I can get the volume to come up. Hold on, wait. Working. Okay. Really? So I guess, since I can't get the volume to work, and I don't want to sit here and mess with it because I don't want to miss out on the fun part, just watch this video. I have it listed on your PowerPoint and I have it in your actual module for today. Okay, so it's just a review of the actual respiratory system, what it does. Okay, again, this is stuff you learned in anatomy and physiology. This is stuff you should know. It's just a review. Okay. And it's a really neat review. Like I said, I'm a visual person, so it really helps me. Okay, so again, we talked about that nose. So the nose, it warms and filters and humidifies our air. Okay, so filtering, what does that mean? Okay, kind of cleans it. So those little hairs that are in there, and then the mucus that's there, what does it do?
Capture bacteria.
Captures bacteria, captures particulates. It's kind of your first line of defense to prevent that stuff getting into your lung cavities, okay? Humidifies the air because, again, we need to have warm, moist air is better than dry, cold air, okay? So that's one of its jobs. You have your mouth, pharynx, epiglottis, larynx, trachea. And then you have the carina, which is this part here where it branches off. The bifurcation. Your lower is the bronchi, bronchioles, alveolar ducts, and alveoli, which is actually the plural word. One alveoli is an alveolus. Okay, so if you ever see alveolus, that's just talking about one of those little sacs. And then you have your right and left lobes, and everybody should know your right lobe has, or your right lung has 3 lobes. Your left lung has 2. Why does your left lung only have 2? Because your heart's there. Okay, you don't have as much space on that side. And so ideally, we're going to think that's how it was created because of the heart. Okay, so structures and functions of the respiratory system. So the alveoli is the primary site for gas exchange, okay? The pores of cone, this is the interconnections between the alveoli. It allows the air to pass and also bacteria. So basically your alveoli have these little bitty capillaries that are around them. As that air goes through them, then it diffuses into the blood system, okay? This is, again, basic biology and anatomy. So what are some things that you consider about our older people? So structural changes. What happens when you get older? You start to kind of sometimes bend over, right? So if you have a kyphosis or a curve in your spine, do you have as much lung capacity? No. Okay. So you have reduction in chest expansion and functional alveoli. We also have other defense mechanisms that are reduced. Your immune system sometimes doesn't function as well the older you get. Those respiratory muscles tend to become weaker and decline progressively after the age of 50. They have a more gradual response to changes in O2 and CO2 levels. Okay, so you may not see that initial shortness of breath, traditional changes that you'll see. Okay, does anybody know what the most common sign of an older adult with decreased oxygen level is? Altered mental status, confusion. Okay, you may not see those other things like tachypnea, retractions, all those things. You don't see those. You initially, a lot of times, will just see confusion. So in your book, there's a table that has all of it broken down as far as that older adult. Quiz. What is the primary function of the respiratory system? To supply oxygen, to help red blood cell production, to supply carbon dioxide to the bloodstream, to supply body with unoxygenated. Good job. To supply oxygen to the bloodstream, okay? And then to also get rid of the CO2, okay? We don't want to bring CO2 in. We are getting rid of it. There. Okay, so we have to do an assessment. When we have a patient who comes in that has a respiratory difficulty, we need to do a very good assessment, okay? So we have subjective and objective things that we're going to be looking at. So health perception. What is that health management pattern for that patient? So ask the patient if there has been a perceived change in the health status, okay, within the last several days, months, or years. In COPD, does the lung function decline slowly? It declines slowly over many years, so the patient may not notice the decline because it happens slowly. Okay, so it's not going to be something that's immediate. Explore common manifestations of the respiratory problems. So tell me some things that you're going to ask about.
Have they been short of breath?
Have they had shortness of breath? Any cough? Congestion. Are they having trouble sleeping? Do they have snoring issues? Yeah, you have to question, okay? They come in and say, well, I can't breathe. Well, apparently they're breathing because they're there with you, right? So then you need to further assess what's going on with that breathing, okay? Explain to me, describe to me, okay? Oh my goodness. I know why everybody's clicking. So then we're going to look at the medication. Okay, we need to know what kind of medications they're on. Over the counter, any illicit drugs they're using, any oxygen that they're on at home. Okay, we sometimes don't think of oxygen as a medication, but it is part of the medication list. So we need to know, what do they have to wear, when? Do they only wear oxygen at night when they sleep? Do they have to wear oxygen 24/7? Okay. Have they changed the liters they use at home because they feel like they're not breathing as well? Because let me tell you, they'll do that. Okay. Doctor has you on 2 liters and they bumped it up to 6. Okay. And so you need to know those things. Okay. What other surgeries and treatments have they had? Okay. In that past medical history, we need to know what kind of respiratory disorders they have had in the past, things they've been exposed to. So maybe they weren't a smoker, but can someone tell me some other exposure things that we need to be aware of? Secondhand smoke. Environmental. What was their job? Did they work in a coal mine? Did they work in a factory that processed types of plastics? Okay, that has heavy chemicals. Did they work as a truck driver hauling sand and rock? Okay, those things, they're exposed to the respiratory system's exposed to things. Okay. So then the smoking, okay, we need to know, are you a smoker? What is your exposure to secondhand smoke? What has been your change in respiratory status? Okay, what other symptoms are you all of a sudden having? How is that cough? Now we know how the cough is, and they're telling us they're coughing stuff up, what do we need to know about that? Color, amount, is there blood? Okay. We need to know about those things, because if we have someone who's coughing up sputum with some red streaks versus coughing up frothy, reddish fluid, that's going to let me know that they either have with the redness and just the yucky congestion, that could be an infection. But if it's that frothy fluid-like material, then they have some fluid in their lungs. Okay. So that's why it's important to know the consistency, what it is, what color it is, have them describe it to you, because it's going to be, just because they're coughing stuff up doesn't mean it's automatically an infection. It could be something else. It could be just they have a lot of excess fluid on the lungs. So now we need to figure out, are we getting CHF? You know, why are they retaining fluid? What is the reason behind the fluid? What immunizations they have received. Okay. So what are some immunizations that can help with the respiratory system? Pneumonia. There is a tuberculosis vaccine, but we don't usually do it here in the United States. Influenza, the flu vaccine. One more. Huh?
One for whooping cough?
Okay. Pertussis, but one more after that. COVID. Thank you. Nobody thinks about that because it's so new. Okay. If we have someone that has a higher risk of developing respiratory disorders, we need to talk to them about immunizations. Okay. What can we provide for them to help them prevent possibly being exposed, if they are exposed, being put in the hospital? Okay. And we know just because you get the flu vaccine, does that mean you're not going to get the flu? No, you could still potentially get the flu, just like with the COVID vaccine. But what happens? It shouldn't be as bad because your body has those antibodies built up. Okay, you have those antibodies built up, and therefore your body should begin to fight it. You're still probably going to have symptoms, but they should be very minimal compared to someone who's unvaccinated. Now, is that always the rule of thumb? No. Sometimes you do have someone who's vaccinated that gets a severe case and ends up being hospitalized. Okay, but if you look at the majority of the people hospitalized, those are unvaccinated people. Okay. Oh, genetic risk. Sorry, I missed that one. So what are some genetic things that we can think of? It's on the bottom of the other slide. I can't go backwards. I hear whispering, but I can't hear what you're saying. Cystic fibrosis. That's the most common one we can think of, right? Okay. Someone who has cystic fibrosis, they are going to have respiratory issues their entire life from birth. Okay. Anything else? That one's not necessarily genetic. If you could have a higher risk if you have some lung disorders. Asthma. Asthma does run genetically. Okay. If there's a family history, you're at risk of having it. Okay. So asthma is another big important one. So then when we're also looking at subjective data, we have to look at what are their functional health patterns. Okay. So what is their nutrition? Okay. This is important when you're breathing. If you have someone who's an overweight, heavy person, they already have COPD and difficulty breathing, do you think that it's smart for them to lay flat on their back at night to sleep?
No.
No, because we're going to add pressure into that chest cavity, reducing the expansion of the lungs when they already have issues with that. Okay. So we need to look at their nutritional status. So have they had any changes in their health? Okay. Have they had any changes in their weight? Excessive weight gain. If we have all of a sudden an excessive weight gain, what do we consider could be possibly going on? Fluid retention. Okay. We have excessive weight loss, then something else is going on. There's something metabolically going on in their body. Again, we're going to explore some common manifestations of what's causing some of those issues. We want to look at elimination patterns, okay, incontinence. So if you have someone who has difficulty walking from their chair to the bathroom, incontinence may not be necessarily because they're having bladder issues. It's because they're having issues getting up and being able to walk to the bathroom. They can't breathe, okay? So it's just easier for them to wear a pull-up or an adult diaper and use that rather than get up and walk to the bathroom, okay? Girls, what's another incontinence issue? You have a baby, what happens when you sneeze? You pee, okay? So then the older you get, the worse it gets, I'm just gonna tell you. And so you'll have these women who maybe had 2, 3, 4, 10 vaginal deliveries, and now their bladder is falling out of their vaginal canal. And every time they sneeze or cough, they're gonna have incontinence, okay? So they're having constant incontinence related to COPD, and they're having a constant cough. What are some other of our risk factors we need to consider? Skin breakdown, because urine is very acidic, very acidic. It can break down that tissue, okay? And so if you have someone who's having issues going to the bathroom, either due to not being able to get up and walk or incontinence related to coughing or whatever, we need to also then further assess skin because we're going to have breakdown. Assess at that time for any difficulty breathing. If they're a smoker, we need to know what their smoking patterns are. Dehydration. Why is dehydration a problem?
Skin integrity.
Okay, skin integrity. What else?
Dry mucus.
Okay, right. If you don't have fluid, then is that mucus going to be thin or thick? Thick. Okay, and you have someone who has COPD that's producing mucus and they're very dehydrated, that mucus is going to be thick consistency. They're not going to be able to move it. Okay, so dehydration is a problem just almost as much as overload of fluid. Okay. When you're talking to them about exercise and activity, you need to find out what are they able to do. Okay, what are their limitations? Can they get up and walk to the bathroom? Can they walk up the 3 steps from their garage to the house? Okay, what can they do? And then what can they not do now that they have been able to do? Okay, we've got to assess what were they able to do just 2 weeks ago and now all of a sudden they can't. So that way we can figure out why. We also need to look at the residents. Some of you have already gone to your home health and you've actually got to go in a house and see someone's home. Not only are you assessing that patient, but you have to assess that environment, okay? We already talked about fall risk last semester, and we have to look and see what are our potentials for that patient having respiratory issues related to maybe lots of dust and dander because they're not able to clean their house, okay? Maybe respiratory issues because their bathroom is down the hall at the end of the hall and they sleep in the living room, okay? And they can't get up and go to the bathroom, so now we're having incontinence issues. So what is one thing you could think of that could be a resolution to that?
Bedside commode.
A bedside commode, right? As a home health nurse, we could then provide a bedside commode and just, say, home health will be in once a day to help empty it, or have your family come and empty it after work. But that would be a way to help reduce that skin breakdown due to incontinence, providing a bedside commode that's right there by their chair that they sit in all day, okay? What position changes are they able to make to help it? Okay, can someone tell me if you have a COPD patient, what's the most common way they will sit? Tripod position, right? They're going to lean over like this, okay? Usually on a table, on a chair, and you would think that compresses, but it helps to open that back. They're barrel tested so that they have more space all the way around, so they're able to kind of open up the chest cavity better in this position. Okay, so you'll notice, if someone's having difficulty breathing as a COPD patient and they don't know how to do the tripod position, that's one thing we will educate them on, okay? Then what positions make it worse, okay? We need to know what that could be. What can they do as their ADLs? What are ADLs? Activities of daily living. So can they cook for themselves? Can they brush their teeth? Can they bathe themselves? Are they able to walk to the bathroom? Can they dress themselves? Those are important things to know. And we need to know what were they able to do, and then over time, no longer able to do. Okay, because if those have changed, especially recently and quickly, then we need to assess further what's going on with the respiratory system. True or false? Subjective data is info from the patient's point of view, i.e. feelings, perceptions, concerns attained in the assessment. Subjective data. True. Okay. So subjective is what the patient is telling you. Okay. Objective is like what we can actually measure. Labs, x-rays, O2 saturation, blood pressure. Okay. So subjective is more so what we're being told. Okay. Objective is what we can actually measure or see. And we learned that last semester, but I threw it in there. Okay, assessment of respiratory systems further on. So we're looking at more subjective data. We talked about their sleep pattern. We need to know, how are they sleeping? Do they wake up a lot at night? Okay, with pulmonary problems. A patient with asthma or COPD may wake up a lot with chest tightness, wheezing, coughing. Okay. They might need another therapy to help them sleep better at night. The patient with heart disease may sleep with the head of the bed elevated on several pillows to avoid respiratory problems brought on by lying flat. A lot of COPD patients, they recommend a wedge or even having a hospital type bed in the house to help them sleep at an elevation. Excess weight, again, can interfere with sleeping patterns because when you're laying flat, you have that excess weight going into the chest cavity. What is their cognitive perceptual pattern? So are there neurological changes going on? Okay. So hypoxia can cause neurological problems. Ask the patient about their apprehension, restlessness, irritability, memory changes. These patients who have respiratory difficulty are very anxious. Okay. They're very restless. A lot of times you're going to see they have prescriptions for Xanax, Ativan, and this is because, can you imagine having that feeling all the time that you can't breathe? That would make you anxious, okay? And so a lot of these people have to have anti-anxiety medications to help reduce that so they can feel like they can breathe, okay? We need to assess their cognitive ability because if you see changes from one week to the other, that's pretty quick onset, then there's an O2 saturation issue, okay? They're hypoxic. They're not getting enough oxygen. We need to ask about discomfort or pain when breathing. Okay, if they're complaining of chest pain, we first need to rule out what? Heart attack. Is it heart issues first? Okay. Anytime anybody complains of chest pain, young, old, healthy, not healthy, doesn't matter. Initially, we always need to consider heart. Once we've ruled heart out, then we need to look and see is there other issues going on with their respiratory disorder that they have. Careful assessment of the patient having pain when breathing, such as onset. We need to know when it happened, the exact location that it is in the chest. Are there anything that makes it better? Is there anything that makes it worse? Okay, and this can help us establish a diagnosis possibly. Now, as nurses, are we going to diagnose? No, but we can then better inform our physician of what the patient is dealing with and having and complaining of. Okay. Role relationship patterns, okay? So acute and chronic respiratory problems can seriously affect the performance at work and other activities that they like to do, okay? So sometimes medications, oxygen therapy, and other special routines can impact that patient's daily life, okay? They're not able to do life exactly the way they were able to do it because they're having to stop and do nebulizing treatments, having to do inhaler treatments, and having to carry oxygen with them. We need to look and see what kind of job they have. Are they continuing to work in an area that's potentially causing their respiratory problem to be worse? Maybe they have a hobby that could be causing their respiratory issue to become worse. What do you think? Think of some things hobby-wise that could potentially cause respiratory disorders or aggravate them. Carpentry, yeah, woodworking, because you've got all that sawdust, that little bitty pieces of sawdust. What else? What? Hiking, right? You're out in the pollen, in the lower O2, and if you're going higher up into the mountains, okay, not able to bring in as much oxygen as they need. Now, I don't even think I'd go hiking, but you never know. Maybe they are one that likes to go out and have a campfire every time they go camping, okay? That's going to aggravate, the smoke is going to aggravate their COPD or their asthma. So we've got to look and see what are some things that they can change Not necessarily that they have to give up everything, right? But look at maybe some potential other hobbies related to something they like that is not going to be as aggravating to that respiratory disorder. Okay. The fun part. When I was doing this lecture over the weekend, I was like, oh, yay, we get to talk about sex again. Story of my life, New York and OB. So this is going to impact the person, right? You got to be able to breathe to have intercourse, okay? So it can greatly impact people's relationships, okay? There are people with COPD that are young, in their 50s, because 50 is young, guys. I'm almost there. Now that I'm almost there, I'm like, oh my gosh, that's young. And so they could still have 40 more years of their life to go, and you have this spouse, this partner that you love, and you want to show them that you love them, and now you can't because of respiratory disorders, okay? So we've got to look at how can we assist them and help them to understand better ways of accomplishing that intimate relationship with their partner, okay? Maybe they need to make sure they oxygenate well before. Maybe we need to look at position changes. What are some things, some positions that they can be in that's going to help them to achieve that intimacy, but not cause too much impact on their respiratory system, okay? You never thought as a nurse you would be talking to someone about their sex life, but you will be, okay? It happens. Maybe they need to make sure they're using their bronchial dilators or medications or inhalers prior to, okay, to help give them a more ability to take deep breaths, okay? We got to also look at their coping and stress. Okay, we talked about them being anxious already because they can't breathe, right? Can't breathe. That's going to be anxiety. They're stressed because now they have a medical diagnosis that they're having to be treated for. Okay, it's impacting their daily life. So it's a lot of added stress to already most people's stressful life. So we not only need to see how are they physically with their respiratory system, but how are they emotionally? How are they dealing with all this added stress and new diagnosis? Okay. Maybe we need to look at the anxiety dyspnea cycle. So again, we talked about shortness of breath. They're going to have anxiety. Maybe they need to go to a support group, pulmonary rehab referrals. And so there's actually places that go and you actually work out your respiratory system like you would your body to help strengthen it. So that way, and develop techniques on how to continue to strengthen it so you can breathe better. Okay. What is their value and belief system? Okay. Are they one that is going to follow the recommendations of their physician? Does it follow their belief system? You have some cultures and religions that don't do a lot of medical intervention that is like through prescriptions or over the counter. They do more herbal or holistic forms of treatments. Okay. And so again, when you're looking at medications, it's very important when you have a patient that does more holistic type treatments, you need to find out what those are because it can interfere with other medications that they're taking. Okay. We also, if maybe you have someone who is having a difficult time keeping to the regimen, because it is a regimen. It's not just you take a pill once a day. You have lots of different things you have to do throughout the day if you have a respiratory disorder. If they're not able to stick that, ask questions, find out why. Is it a belief system? Is it a cost? Does their insurance cover the medication the provider prescribed? Okay, does every insurance cover all medications? No. A lot of times there's other medications they want you to try before you have to use the more expensive type medication. And so, maybe they didn't even think to ask the provider after the pharmacy said, okay, this is going to be $400 for the month. And they're like, okay, I can't afford that. I'm on Social Security. Okay. And they didn't think to call the nurse or the physician to say, hey, this is more than I can spend. They just didn't pick it up. Because that happens. Okay. So we as the nurse have to be an advocate then and see, is there a program with that pharmaceutical company that helps people that are low income? Is there another medication that's comparable that's cheaper that we can look at? Maybe there's another pharmacy. There's a card called GoodRx. When it first came out, I was like, oh, this is a scam. It really is not. They actually go through and basically all those different coupons that pharmaceutical companies offer, they streamline it through one system, through their system. And so then you can go on their website, type in the medication, and it will tell you what pharmacies in your area, what the price is. Okay. So be an advocate for your patient and telling you, I can't afford it. Ask them, have you heard of GoodRx? Okay. There's a free option, and then there's a couple other options. One that's like $9.99 a month, and you can get better discounts. Okay. $9.99 a month is doable for some people. Okay. Especially if you're only going to have to pay a fraction of what you would pay. So again, you're being an advocate for your patient. So we're now on to our objective data. Okay, remember, subjective is what they tell us it is. Objective is where we can see what's going on. We can look at those lab results. We can look at that x-ray. Okay. So our physical assessment, first and foremost, what do we always do? Vital signs, right? So what part of the vital sign is going to tell us how their oxygen is? Respirations and O2 saturations. Okay, we need to know how they're breathing, how many times a minute they're breathing. Is it fast? Is it slow? Is it labored? Is it non-labored? Okay, so we're not just counting, right? We're looking at the actual process of them breathing. Do we see them gasping? Do we see retractions in places? Okay, and again, remember that's that pulling of the tissue, like around your collarbone, in between your intercostal spaces, below your xiphoid process. Okay. How is their breathing pattern? Okay. And then what is their O2 saturation? Can someone tell me, when I'm looking at that saturation, how long ago is that in their respiratory system? Let me know. Is it immediate? Is it what their oxygen is now? No, it's about 2 to 3 minutes ago. Okay. So you're going to see someone maybe who, was doing good, and all of a sudden you hear the machine go off, you go in there, and now they're breathing better, but maybe a minute ago they were having a little bit of respiratory difficulty, and you're like, well, why is their O2 saturation 88? They're breathing fine. And they'll tell you, well, I just had a little bit of shortness of breath. Okay, well, it's because it was about 2 minutes ago. Okay, so ideally it's going to give us the best count now, but it is a little delayed.
So you would wait 2 or 3 minutes to check it again?
Yes. And most of the time, if you have someone that is desetting or has a constant, you want to just leave it on them. Get that I have a little finger one that's my own that I keep with me sometimes because I can't get my machine in there fast enough. And I just pull it out of my pocket and stick it on their finger. That's like $10 on Amazon. Okay. And it's going to allow me to monitor it until it comes up, and then I can go grab an actual machine from the facility and maybe put them on. And with pulse oximetry, you do have to have an order. But if you have a patient who desats, most of the time that's one of those standing orders that your physician will have. That way you can go ahead and apply that pulse oximetry. Because I can tell you your physician is not going to want you to call them at 2 o'clock in the morning and tell them, my patient desated down to the 60s for 30 seconds. So I was just calling to see if I could put on a pulse oximetry. They're going to fuss at you. Okay. That is one of those interventions as a nurse that you have nursing discretion, okay? And you usually have a written standing order for something like that, okay? We want to also look at the nose, okay? Your book talks about going in and actually, using nasal speculum, looking with a light. Your physician's going to do those type of things, but you can ask, have you had any bloody nose? Are you having any mucus discharge? What's the color? What's the consistency? Look visually, is there any deformities? Okay, do they have a deviated septum? What does that mean? The nose is crooked, right? Maybe they have a broken nose. So, the majority of people don't have the most perfect straight nose. If you were to measure one side, it's closer to one side or the other, but you can actually see when someone has like a break and it's really deviated, okay? Is there symmetry, okay? Is there any discharge? So if I have a patient who comes in and complains about that, a couple weeks ago, they were in a car wreck and they didn't come in to get assessed because, they felt fine, but now they're having a clear drippy discharge from their nose. Potential spinal fluid, okay? Or maybe they had a trauma to the head, they felt fine, didn't get it checked out, and now they may have a crack to where they're leaking spinal fluid. If anybody ever says they have a clear, watery discharge from their nose, yes, it's related to mucus because sometimes, that happens, but you want to further assess because it could potentially, especially if they've had any trauma, be spinal fluid. Okay. So that's why it's important to know the color, the consistency, what does it look like? Okay, how often is it happening? You're gonna look at the mouth and the pharynx. Okay, you're gonna have them say ah. Okay, if you have to use a tongue depressor to see further back, because some people can't open their mouth so you can see those tonsils. You want to look at the color. You want to look at the gums. Are they healthy? Okay. You want to look for false teeth. Okay, I'll tell you a story. So I had a patient one time, not too long ago, who was having to have an emergency C-section because baby was C-selling, and she spoke Spanish, and I had asked her if she had any problems with her mouth, because I didn't know how to really ask, do you have any false teeth or loose teeth at that time. I had since learned how to ask that in Spanish. Okay. And of course, we're in a hurry because we got to get baby back, or get her back, get baby out, you know. Anesthesia's in a hurry. We get her back there. Epidural's not working, so they have to intubate her. Guess what? We had a plate with 1, 2, and guess where it went? So, very important. Guess what I do all the time now? I look at people's mouths. Okay, they may tell me, oh no, I don't have any loose teeth or false teeth, but I look. I'm like, I don't believe you. Okay, so it's always important to assess. Look at the gums. Look and see if they have any issues with ulcers. Do they have any signs of strep throat? Do they have any signs of candida? Okay, you can get thrush as an adult. What person would be at risk for thrush as an adult? Old people? No good oral care? Maybe immunocompromised, or one specific diagnosis I'm thinking of. Diabetes, because their sugar level's always elevated. Yeast loves sugar, okay? And so they can have yeast infections and folds of their skin around the vaginal area, the penile area, the anal area, in their mouth, okay? If they're having constant high blood sugars, they're gonna have yeast somewhere, okay? You wanna look at their neck, okay? You wanna look and feel, see if the trachea is midline, okay? It can be shifted one way or the other. This can be signs of like atelectasis, pneumothorax. There's lots of different respiratory issues that can cause the pushing of that trachea one way or the other, okay? Then you wanna feel for lymph nodes, okay? So has everybody felt lymph nodes? You know, inflamed lymph nodes? You know, if you feel your neck now, it feels normal, but if you're sick and your tonsils are swollen or your kiddos are sick, you're gonna feel those lymph nodes swollen, okay? You'll even have some develop up behind the ear, okay? So kind of get used to what that feels like. How's it different? And do they have any tenderness? Do they have any other swelling? Okay, what else is in our throat that we can assess? Thyroid, tonsils and thyroid. Our thyroid's right here, okay? Right above that little dip in your bone. Your thyroid's a butterfly shape, so if you feel it enlarged, okay, or a knot on one side or the other, you need to let the physician know. Quiz. Objective data is made of which parts? Select all that apply. Objective data is made up of which parts? Oh, no, I spelled one word wrong. Palpation is the blue. Inspection, percussion, palpation, auscultation. Select all that apply. All of them. Yep, they're all objective, okay? Inspection, we're looking, we're seeing, right? Palpation, we're feeling. Percussion, we're listening, we're looking for that resonance. Auscultation, we're listening to the lung sounds, the heart sounds, the abdominal sound. Oh, who's great? Okay, so assessment. So we're going to look at that thorax and lungs. So through inspection, palpation, percussion, and auscultation. Okay. When assessing a patient, you can assess their posterior and anterior, or anterior, posterior, okay, anterior, posterior. You want to listen on both sides, okay, because you want to hear the front of the lungs, the bottom of the lungs, and especially on women, it's really hard to hear your lower bases because of our chest tissue. So you want to listen in the back, and you want to make sure they're taking a big, deep breath, okay? Normal breathing isn't going to get down to those bases where you can actually audibly hear it. So you need to have them have big, deep breaths, okay? So we're going to do several different things when we're looking. We're going to inspect, palpate, percuss, and auscultate. So on inspection, we're going to look at appearance, okay? What is the position? Do we see signs of respiratory distress? Tell me some of those signs. Retractions. We have retractions in our clavicles, our intercostal spaces, and below that xiphoid process. What else? Labored breathing. Labored breathing. Maybe in an adult, is abdominal breathing normal? No. In a baby, yes, but not in an adult. If we have abdominal breathing, then that's abnormal. Anything else? Barrel chest. Do we see that rounded? And so barrel, think about, you know, your normal chest is kind of oval, oblong shape. Barrel chest is going to be more rounded. Okay, it's going to be rounded in the front, rounded in the back. Okay, and that's the use of those accessory muscles around that rib cage that then pulls it out and makes it more rounded. Okay. So, I mean, labored, like when you're just sitting here talking to me, I'm watching you, you're not struggling. Someone who's labored is going to be more like, okay, now I can talk to you, Brad. I'm going to keep on breathing. You know, you're going to see the activity. Most people, when you're sitting and watching them, you can see them breathing, but it's not something that triggers you to pay attention. But if you see, you know, a gasp, or you're having to see them use their full chest motion to breathe, maybe they're having to say, oh, I need to sit up. You know, look for those key signs that shows that they're more labored than just a normal respiratory effort. Okay, because your normal respirations, your brain doesn't have to think about it. That's one of those automatic systems. But if you see someone who's actually having to work at it, you're going to see the difference. Okay. We want to look at the respiratory rate, the depth, and the pattern. Okay, you want to know, is it fast, is it slow? Are they having to take those big, deep, gasping breaths because they feel like they can't get enough oxygen? What do their skin and nails look like? So tell me someone that has like chronic COPD or chronic hypoxia, what are we going to see on their hands?
Oh, blue.
They're going to be cyanotic. We're going to see clubbing. Okay, and that's where it starts to kind of square off. I will post a picture on our module to show you some of these symptoms. Okay, I didn't have enough room in my slides to show you all. The clubbing of the fingers. You're going to see blue bases. Okay, you're going to see cyanosis in the hands, cyanosis of the lips. Okay, so anywhere that you have that decreased blood supply, okay, so extremities, if the body's having to work and wants the oxygen to go to the major organs, here, you're going to notice cyanosis here and in the feet, okay, and in the lips, because it's pulling the core. Palpation, we're going to talk about that in a second. We're going to look at, again, tracheal position. Is it deviated one direction or the other? How far can they expand? And phremitis. So when you're looking at the assessment of the respiratory system, you are, let me go back to this one. Okay, the picture that was there before. So what she was doing is when you're assessing, you're wanting to see how far does someone have to expand to breathe. Okay, so you're going to put your hands kind of at the diaphragm base, either in the front or the back. Okay, and when they're not taking a deep breath, you're going to get about tip to tip with your thumbs. When they take a deep breath, it should only expand by 1 inch. Okay, if you're expanding further than 1 inch, then that's someone who's having to really work to get that deep breath. Okay, that's abnormal. Normal expansion should only be 1 inch. If you have greater than 1 inch expansion with your hands, then that's abnormal. Okay. So the other thing we're talking about is phremitis. Okay. We kind of briefly I touched on this when we did respiratory in the pediatric patient when we talked about assessment. So phremitis is the vibration of the chest wall made by vocalization. So when we say words, So you can feel the tactile phrenitis by placing the palmar surface of your hand, so the palm of your hand against the patient's chest. And you want the fingers kind of hyperextended, so you're kind of like a cup position, okay? You're gonna have the patient repeat something like 99, or boy, oh boy, toy boat, blue balloons, okay? And a deeper, lower, but normal voice, okay? At the same time, then you're going to then do high, mid, and low with your hands to feel. The tactile phrenitis is most intense by the sternum and between the scapula because these are the areas that are closest to those major bronchioles. It's less intense farther away you get, so the lower you get, the less you should feel. So if you have an increase, a decrease, or an absence of phrenitis, with that increase, that could mean that the lungs have been filled with fluid, so it's denser. If you have a decrease, then the lung could be hyperinflated due to like pleural effusion, or they're barrel chested. If it's absent, then you could have what's like a pneumothorax or atellaxis. So you have too much buildup of air in one spot that's not moving. Okay. When you're listening to the lungs, again, you're going to go across, down, across, down, across, down, across. Okay. You also can listen on the side and again in the back. Okay. And the reason we're comparing one side of the lung to the other. Okay. So sequencing is very important. We're listening for different sounds. Okay. A dull sound. Talking about percussion now. So when you percuss, now, of course, again, this is something most of your physicians are going to do, but it doesn't hurt to practice. So get your little kid out there and you percuss, and you basically put your one finger on there and you tap it. Okay. Kind of like, does anybody ever go dump their watermelons when they're buying a watermelon? I do, because I want a good watermelon. Okay. So I get my lines really wide, a good, nice yellow orange spot, and something. Okay. If it sounds more hollow, I got more water and it's good. Okay. So that's what we're doing on percussing a chest, like thumping a watermelon. Okay. So if we hear a dull sound when we tap, then that means, so our description should be sound with medium intensity pitch and duration heard over areas of mixed solid and lung tissue. So such as the top of the liver, particularly consolidated lung tissue. So like over here, right under where your liver is and your lung meet. Got the diaphragm there. That's where you're going to feel like more dull. Okay. Flat, so this is a soft, high-pitched sound of short duration heard over very dense tissue where air is not present, such as the posterior chest below or just below almost the diaphragm. Okay, so that's where it's denser. You're not going to hear very much. Hyperresonance, this is the sound, high-pitched sound of short duration heard over very dense tissue where air is not present, or sorry, loud. Hyperresonance is a loud lower pitch sound than normal resonance heard over hyperinflated lines, such as chronic COPD and acute asthma. And then resonance tympani, these are two others. Resonance is kind of like a low pitch sound heard over normal lungs. And tympani is kind of like a drum-like sound. Okay. Do I expect you to know these? No. Okay. Again, your physician's going to be more so the one that's going to percuss. But it's kind of neat just to hear. I actually percuss babies' bellies because if you see a big full belly, if you kind of tap it with your finger and it sounds hollow, there's tons of air in there. Okay, then I know that baby needs to be burped better. We may even need to drop an OG and kind of suction the tummy out. If they're taking in more air into their abdomen, then that can tell me we may have a respiratory issue because if they're breathing faster and deeper and they're pulling air to their abdomen, then they're working to breathe. Okay, and so that's another thing we assess on a newborn. So I actually will percuss the baby's belly, and if I can hear air, kind of like that drum-like sound, then I know that we've got excess air. We got to figure out why. Okay. Auscultation. So again, you're going to listen side to side. You're going to do anterior and posterior if you can. Okay, sometimes in emergent situations, you may not be able to listen to both sides, especially if they're laying on a backboard because they have a neck injury or whatever. But we need to try to listen as well as we can, so you can do anterior and lateral. Okay. So again, this is just a good diagram of the actual respiratory system. So this, I think a lot of people don't realize this, but the actual base of the lungs go down behind the liver. Okay, your liver is in front of the base of those lungs. Okay. This is talking about the different areas that you're going to hear. So you've got the liver dullness, that's going to be that bump or that dull sound. Stomach, you're going to hear tympany. Okay. Then it's showing you on the back the different areas that you can percuss and what you'll hear. Okay. Auscultation. So when you're auscultating, there's 3 sounds we want to hear, or we could hear. Okay. And these are normal sounds. We've got bronchial, bronchiovesicular, and vesicular. Bronchial sounds that are loud, kind of high-pitched sounds that resemble air blowing through a hollow pipe. Okay, so this is through those bronchioles that branch down. You're going to hear bronchial sounds on inspiratory and expiratory. So when you're having someone breathe in and out, you're going to hear the flow of air in and out of those lungs. Okay. You're going to hear a gap between the two. You should hear kind of a space between because they're breathing in, stopping, breathing out. Okay, and that's very common. That's how we breathe. To hear the bronchial breath sounds, you're going to place the stethoscope next to the trachea in the neck. Okay, because that's going to be your main branch, because then it's going to branch down under. Bronchovesicular sounds, they have a medium pitch and intensity. They're best heard anteriorly between the first and second intercostal space. So right in here. Okay. Bronchiovesicular sounds have a 1-to-1 ratio, so that inspiration and expiration are going to be equal. Vesicular sounds are kind of soft, low-pitched, gentle, rustling sounds, and these are heard over all the lung areas except the major bronchi. So this is all the rest of your lung. Okay. So with inspiration, you're going to hear it's going to be 3 times longer than expiration. So when you breathe in, it's 3 times longer than when you breathe out. A little faster when you breathe out. Quiz. A client with asthma reports shortness of breath. What is the nurse assessing when auscultating this client's chest? Adventitious breath sounds, oxygenation status, heart rate and pattern, respiratory excursion. Gave you longer for this. Think about it. Okay, we're almost there. Adventitious breath sounds. Okay. So we're going to talk about that in a second. What is adventitious breath sounds? Good job. So these are abnormal or adventitious breath sounds. Okay. So when you have someone who is in respiratory distress or has a respiratory issue, most of the time their sounds are not going to be normal. Okay, their lung sounds will be abnormal at times. And so what we're listening for is listening for crackles, fine course, and I have a link in here. It's not gonna load it because I don't have any volume. I gotta call IT to figure out why. So this link here, I will have it uploaded on your module. You can go to, and it actually, these are really amazing. I've not ever found this website until I was doing some research for this one. But you can go on there and listen to what wheezes and crackles sound like. And they have them not only in just like adults, but they have them in pediatric patients and newborns. Okay, so there's a bunch of different links that you can click on and listen to these breath sounds. Okay, so crackles, fine or coarse. So they're going to be, crackles is kind of like the snap, crackle, pop. Think of Rice Krispie treats. Okay, what does Rice Krispie treats sound like whenever you pour milk over them? You've never done it. Okay, it's going to sound crackly. Okay. Wheezes is that music-like sound, kind of like a whistle that you'll hear. Stridor is somewhat musical also, but it's a little bit more like you're going to hear it, not just here, but you're going to hear it when they take a breath. Sometimes wheezes you can also just hear without a stethoscope. The stridor you're going to hear without a stethoscope. It's just going to be audible. Pleural friction is going to be like a rub. Okay, it does kind of sound like a rub. And what it is it's because that pleural space has either water or fluid or air in there and it's rubbing. Okay. So some abnormal voice sounds that we could hear is egophony. So egophony is whenever you're have someone say E while you're listening to their lung sounds, and it changes to an A sound when you're hearing it in the lung. Okay. So this means they have a fluid filled, consolidated, or compressed lung. So like a pneumothorax. Bronchophony, this is when you're auscultating the lung sounds, the patient is asked to say 99. Bronchophony is present when you can hear the 99 louder in the lungs and it's more distinct over certain areas, suggesting underlying consolidation. So maybe there's consolidation lower down, but you can hear the 99 right above it really well. Okay. Whispering, pectorality. The patient is asked to whisper 1, 2, 3, or 99. With this, you're going to have, if it's present, the whisper is heard more clearly over certain areas, suggesting an underlying consolidation, kind of like with the other one. So these are just ways to assess to see if there's actually fluid or anything there without having like an X-ray. Again, I can go to the link, it's just not gonna be, you're not gonna be able to hear it. Like my, yes. Okay, diagnostic studies of the respiratory system. So how are we going to objectively further assess? Okay, so we've looked, we've palpated, we've listened. Okay, so now we're gonna do some other objective assessments. Everyone in here should know what an SpO2 monitor is, right? Pulse ox. We're looking to see what the pulse ox is on the patient. So 94 or 92 to 99 is usually kind of, most doctors will say oxygen to keep O2 saturation above 92%, okay? And then you can wean them down if they can stay above 92 without the O2, then you can take them off. So they'll usually have a continuous pulse ox also, so that way we can monitor what the SpO2 is. We're also going to, there's several places you can put the pulse ox. Can someone tell me?
Ear.
The ear, the finger, the toes, okay, kind of those extremities. If you have someone who is moving a lot of times you can do the earlobe, but you can also sometimes do the forehead or the bridge of the nose.
You said that they had Victoria surgery on the forehead.
Yeah, because it's sometimes if you can't get it anywhere else and you need to know that person's saturation without having to do an ABG, then we're gonna put it where we can.
Is there special monitors for that?
Nope, it's the same, because instead of being like the clip-on one, they have ones that are long and have a sticky tape on them that you wrap around, so it's sticky, so you just stick it to their head. Oh. Yeah. So it's just a little bit different instead of being like a little clamp that goes on your finger. It's like a long piece of tape on it. And it has a little light in it. It's what we use on our babies. The other thing that we use are ABGs. Okay, so we are going to just learn the basics of ABGs for level 1, because if you go on to take your LPN test, that is not something you have to know what a regular ABG is. You just kind of need to understand the concept of ABGs. And level 2, Judy will go through ABGs very extensively with you, okay? Because you will need to know what a normal ABG is. You'll need to know if it's respiratory alkalosis, respiratory acidosis, metabolic acidosis, metabolic alkalosis, okay? We're going to just learn the basics, okay? So ABGs are obtained to determine oxygen status and acid-base balance. Okay, so if our oxygen is off, our acid-base balance will be off. Okay, and this is going to affect all of your body systems. ABG analyzes includes measurement of the PO2, the PaCO2, so that's the partial pressure of CO2 in the arterial blood. Same thing with the O2. Acidity, which is the pH, bicarbonate, which is the HCO3, and the SaO2. So normal values for the ABGs are shown in your book on table 25.11, okay? So it's not gonna hurt to know your normals, because if you know what your normal is, and someone hands you an ABG, you're gonna say, oh, that's not normal. Don't know what it is, but it's not normal, okay? And that's okay. Because you do need to know what's normal to know what's abnormal. The blood is pulled from an artery, usually from the wrist, the radial, can also be pulled from femoral. Those are your two most common sites that they pull an ABG from. Who draws the ABGs? That's one thing respiratory is trained to do. They are trained to draw ABGs, okay? I've never had to draw an ABG. Thank the Lord, I'd be scared to death. It can be done. I mean, you're just looking for the pulse, and you got to go between those, because it's actually, there's a tendon and a bone there, so they're having to go between the tendon and the bone to get it, okay? And so you just find their pulse, and that's where you're going to go between to pull the ABG, okay? Usually this is going to be pulled, like I said, just from puncture, but sometimes people can have catheters, arterial catheters in place that you're constantly drawing from. So if you have someone that's on a ventilator or has, you know, in respiratory distress, they may place an arterial catheter. So all you do is just draw from it. So you're not having to constantly poke and draw, okay? For nursing, there's no changes to the O2 15 minutes before the sample, okay? So you're not going to adjust any of the oxygen settings. You need to leave it where it's at, okay? Because we don't want to alter the readings. We need to know what they're at now. You're going to use a heparinized syringe, okay? Because you don't want it to clot. And then post collection, you may need to make sure that you hold pressure for at least 1 to 2 minutes, okay? Because again, that's an artery. It's got more force behind the flow through it, and it's going to potentially cause bleeding under the tissue, okay? Diagnostic studies of the respiratory system continued. So we have CO2 monitoring. So this is capnography. And some of you guys actually got to kind of see some of the capnography stuff, right? And ICU, who was that? Anybody? Can you just tell me about it? No? Okay. So capnography is where you are measuring the CO2 in the body, okay? So there's 2 ways of doing it. You can have an actual transcutaneous CO2 monitor, and you can have an end-tidal CO2 capnography. So the transcutaneous measurement of the CO2 is a non-invasive method of estimating arterial blood pressure using an electrode that's placed on the skin, okay? In capnography, the sensor may be attached to the adapter of the ET tube or the trach tube or even the nasal cannula. So instead of being on the skin, it's attached to whatever is being oxygen, CO2 is being expelled from. Capnography is usually presented as a graph. So these patients, when they're in ICU, you know, they'll have the monitor up there. If they're on a capnography, you're going to have like your SpO2, you're gonna have your blood pressure, your pulse, you're gonna have the cardiac monitor, and then you'll have a capnography monitor that's up there too that will tell you what their CO2 level is. Okay. Sometimes if we need to assess blood gas quickly, they'll do a venous blood gas. Not as accurate as an arterial blood gas, but it's better than nothing if you need something. The SpO2 can be monitored intermittently by obtaining a blood sample from the PA catheter or continuously via a fiber optic sensor and a specific like central line. So if you have a central line, you can pull from that and check the mixed venous. Because like with central lines and PICC lines, it goes straight to almost the heart. And so you're going to have a mixture of oxygenated and unoxygenated blood because you're close to those arteries. Sputum, yuck. Who in here likes to do sputum collections? Anybody ever had to collect sputum? Me too.
For the longest time, I didn't know you had to take the whole little thing apart.
Oh, really?
I would send the whole container.
That's okay. I figured it out.
Yeah.
Sputum, I think if in my nursing career, this is the thing I hate the most. Okay. I can deliver babies barehanded, and I have. That does not gross me out. Sputums grosses me out. Okay. So if you ever have to work with me and I have someone that needs a sputum, I'll probably buy you a coffee or a candy bar or something else so you will collect my sputum specimen for me because I just can't do it. Okay. Grosses me out. Okay. But it's necessary. Okay. So there's several ways of collecting. Okay. We need by expectoration. So having them cough it up. Okay. And one way of having them do that is someone says, oh, I can't cough it up. They can't. So you have to teach them how to huff cough. Okay, we kind of already talked about huff cough. And some of you may not even know what a huff cough is. Everybody know what a huff cough is? Okay, so a huff cough is when you're coughing, but you're kind of using force from here, huffing. So everybody go, like you're forcing, like you're saying, huff, okay? You're doing that while you're coughing. And what that does is it gives more force from the actual bronchioles to bring up whatever's there.
Okay, guys spit
yeah. A lot of people do it, but some people don't, you know.
I don't, but
yeah, I don't either. My husband don't know that. But you actually have them forcefully huff while they're coughing, and that helps to move that sputum, and so you can collect it. Another way is suctioning. Okay, they may just drop a suction down to the bronchioles and suction up some of the sputum. Bronchoscopy. Okay, this is like a little camera. It's kind of firm, but it's malleable, like it's movable, and they're able to kind of drop it down. And usually the patient's awake. My daughter had a bronchoscopy done when she was 4 to look at her actual voice box and epiglottis, and then down into the top part of her trachea. And so they may drop a bronchoscopy in the room and collect specimens that way. So as a nurse, our job is to teach them how to collect it. So you're going to tell them how to cough. Okay. Tell them what they need to collect into the container. Okay. Then again, you may need to figure out how, because I mean, there's so many collection specimen cups just like there is for UA. Okay. So you may need to look at the directions to see then what do you actually need to send down. When they're coughing, when we're collecting the sputum, we also need to assess it. Okay, so we need to look at the consistency, the color. Is there blood there? Is it, again, is it frothy and red, or is it just blood tinged sputum? Okay, that's going to further tell us what is going on with the lungs. Skin tests. So these can be intradermal injections. So allergy testing, has anybody ever seen allergy testing done? Pretty cool. My daughter had it done when she was little. So they actually take, depending on who does it, some places have like this whole big thing that has a bunch of needles on it, and they just at once stick it on your back, okay? And it has all the different allergens that you could potentially be being tested for. Other places, like when she had it done, they used almost, it looked like a little finger sticker, like for diabetic patients, and they actually just would dip it down in there and then did it on her arm in several and did a different allergen in several different places. And if they have an allergy to it, you'll see it react. Like she's severely allergic to dogs. And so they had done like dog, cat, horse, something else. And her dog went spread over to the cat. So they had to retest the cat because they didn't know if it was the cat and the dog or just the dog. And it was just the dog because hers was so bad. And it got red and raised and irritated. And so that just showed that she had an allergy to it. Her body started developing histamines and reacting to that allergen. The other skin test is the TB skin test, the Monito test, okay? This is something you as a nurse will administer at some point, I'm sure, in your life as a nurse, okay? It's done on your patient sometime. If you have a patient who comes in that's possibly at risk for having been exposed to TB or has a history of possibly having TB. A positive result doesn't necessarily mean they have active TB. It could be that they've been exposed, so they're going to do further testing, okay?
Is there a vaccine too where you don't, is it the smallpox? If they have the smallpox vaccine, you don't really
yes, if they have the smallpox or if they have HIV, you're not usually going to do the Manitou test because it can be a false positive. So yeah, there are some, or if they've had the TB vaccine, and some countries do give the TB vaccine, it will show a positive TB skin test. And it's because they have the antibodies. So it's going to show that they've been exposed sometime and they have through the vaccine. So it will be a false positive. So, you know, typically that's what we first get done. So some places, like if you work at Southwest Med, they don't do the TB skin test, they draw blood and they look for the antibodies in your system to see if you have active antibodies. And if you've had the vaccination, you need to let them know. That way they know that that's due to vaccination and not that you've had a history.
Would they make you do treatment?
They just know they'll do further testing to see if it's an active case or if it's just that you've been exposed. Quiz. The nurse is working in an urgent clinic. Which of the 4 clients needs to be evaluated first by the nurse? So which one of these 4 needs to be evaluated first? Client who is short of breath after walking up 2 flights of stairs. Client with sore throat and fever of 101 degrees Fahrenheit. Client with soreness of the arm after a PPD Manitou test. Client who is speaking in 3-word sentences and has an SAO2 of 90%. Who do we need to see first? Okay, so why do we need to see that one first? The green patient.
He's already talking in 3-word sentences.
So what does that tell you? Shortness of breath.
Short.
They're having a hard time working, breathing, right? They're below 92%, which is normal. Now, if it's someone with COPD or asthma, we would say 90 is probably okay. Okay. Why not the yellow? They're breathing, right? They're normally breathing. Yes, they're sick. They need to be seen, but they're breathing okay. Okay. A or red, that's going to be me. Does that necessarily mean I need oxygen at that time? No. It means I need to exercise, lose some weight. Okay. So, yes, shortness of breath after walking up 2 flights of stairs for most people is going to be normal unless you're an athlete or you're a runner or whatever. Okay. But with our patient that has speaking in 3 sentences words, so that's like, I need to go to the bathroom in just a minute. Okay. So if you saw someone talking like that, what would you think? They're working, right? They're having difficulty. There's something wrong. Okay. You check their SpO2 or they just drew labs. Now your SaO2 is 90%. That's lower than normal. Okay. That's who we need to see first. So I threw this one in there because I want you guys to start thinking about this. This is a very common type of question on the NCLEX. Okay. So the blue patient probably needs to be seen. We do something to make sure they're not having a reaction to it. Okay. Red person just needs exercise. Okay. Yellow person needs to be seen. Green person needs to be seen. So we have 3 people that need to be seen, but we have to learn how to prioritize on who needs to be seen first, okay? This is a very common type of question, priority questions, when you take your NCLEX, okay?
What is the PPD into?
What is it?
Yeah.
So it's basically kind of like a form of the TB virus in a way. It's not the actual virus, but it reacts if you have antigens in your system. And so if it's positive, you're going to have like a raised red circular area around where that was. So when you do the test, it's not sub-Q, it's actually just transdermal, so it's right underneath the skin. So when you do it, you just go right under the edge of the tip of the skin and you make a wheel. I love doing PPDs. I'm a little weird. I like poking people with stuff. And so you put it in, you push the fluid in, and it makes like a bubble under the skin. They're not supposed to touch it. They're not supposed to press on it because you need it to absorb. And then in 72 hours, you check it again and you look to see. If it's just kind of red and raised and has no like circular area around it, it's fine. But if you notice that it's more than about 1/4 of a centimeter or more, and it's raised, got a raised red edge, then it's a positive. So that at some point they've possibly been exposed. Doesn't mean they have active TB, but they've been exposed and their body has the antibodies.
So it is like a TB test, but not the same thing?
It is the same thing. Oh. Yeah, it's just another word for it. Yep. Okay, so diagnostic studies of the respiratory system continue. So bronchoscopy, that's where they're actually putting that little camera down into the bronchioles and looking. Direct visualization of the bronchi through that scope. So they might gather specimens, so they can actually put little graspers that go down through there through an opening, and they can collect specimens of the tissue or sputum if they need to. Nursing care before, we need to verify our consent. Now, when we are going in for a patient and having them sign a consent, are we saying that we are telling them about the procedure and educating them? No, we are just saying this person signed the consent. Okay. Verify they have a consent signed, make sure they've been NPO, look and see what type of sedation we're going to be doing. After the procedure, they're going to be NPO until the gag reflex returns. Okay. We're going to monitor for hemorrhage or a pneumothorax, make sure they didn't puncture through the lung and have air escaping into that pleural space. Okay. Quiz. When determining the effectiveness of oxygen therapy, which arterial blood gas value is most important? Tricky. We really didn't talk about it, but which one do you think would be the most important to know how effective their oxygen therapy is? Correct. Whoever picked green, okay? So if we're wanting to know how well someone is oxygenated, what do we need to assess? Their O2 level, right? So in that blood value, we need to see what is their oxygen supply within that blood test, okay? Is it within normal range? Okay. Yeah. PaCO2, it is important because it's going to let us know if they're blowing off enough. But when we're looking at oxygenation, it's how much oxygen is in their blood supply. Who's talking? I'm going to talk with Brian. Breathing. I need to talk with him. It's almost lunchtime. Okay. Lung biopsies continued. So there are several different other ways to do this. I don't expect you to know specifically what these are. Just know that they can actually do either the scopes, they can go through a needle aspiration, they can have a video-assisted thoracic surgery. And it's kind of like this scope, but instead of going down the bronchial, and they actually go in through like the intercostal spaces of the ribs into the lung area. An open lung biopsy, that's where they actually open up the chest and remove tissue that way. Okay. Your main thing you need to know is after one has any type of procedure like this, we're going to be monitoring for respiratory distress, any kinds of a pneumothorax or bleeding. We're probably going to have to place orders to have a chest x-ray at some point to verify we don't have any of those issues going on. We're going to monitor the incision. We're going to do chest tube care, monitor breath sounds, encourage deep breathing, okay? So as a nurse, our responsibility is to assess, monitor, educate, okay? Thoracentesis, this is something you might actually get to see as a nurse if you work on the med-surg floor or in the ER, okay? This is where we're just pulling excess fluid off of that pleural space. Someone tell me where the pleural space is.
In the
chest wall. Yep. Your pleural space is between the lungs and the chest wall. Okay, so you can have buildup of air or blood or fluid in that space. And so what they're going to do is they're just going to put in a needle and sometimes a trocar, sometimes looks like a catheter, or several different types of things they use. Then they're just going to remove fluid off that pleural space. Okay. Then that needle comes out and it doesn't stay. Now, a chest tube is similar, but it's going to stay in place. Okay. We're going to obtain specimen, remove that fluid, and sometimes we can even put medication into that space. Okay. Our nursing care, so before, this is an invasive procedure. So we have to have a consent, just like we would if we were doing a surgery. We're going to help explain the procedure. Of course, the physician's going to do that, but then we're going to continue as we go through the process of what's going on. We may have to help explain what's about to happen next. So that way they're not like, oh my gosh, what are you doing? We need to explain the process as it's happening. During, we're going to help position and monitor. After, we're going to monitor breath sounds and monitor for hypoxia, pneumothorax, and potentially we may have to be then monitoring if they place a chest tube at the same time. We're going to be looking at that drainage, what's the consistency, how much is coming out, because you can pull too much fluid too fast. It's just like you can pull too much fluid whenever you are, drawing blood, or if they have blood loss, if you have that fluid volume deficit, then you're going to cause issues with hypotension. Okay, so you do have to be careful. You can't pull too much fluid too fast. Pulmonary function test. Okay, so with the pulmonary function test, this measures the lung volume and airflow. The results of the PFT can diagnose pulmonary diseases, monitor disease progression, assess response to bronchodilators, and evaluate disabilities. So if you ever have someone that says, I only have 20% lung volume, that's because they've had a pulmonary function test and that's what it shows, that they only have 20%. I have a cousin who's my same age. We were best friends growing up, and he has very minimal lung volume. Darren. She's like, ooh, it's funny. Darren's wife is her aunt, and it's my cousin. Isn't that crazy? Anyway, so as we have people that have this type of test done, then you're able to see what their lung volume is. Okay, so normal is 80 to 100%. So if you have a pulmonary function test and you have 80 to 100%, that's normal lung volume. Okay, if it's anything less than that, then it's abnormal.
So their O2 would automatically be lower?
Not necessarily. They may still have good oxygenation because their body can compensate, but they're going to be at higher risk for overexertion. If they are overexerted, then their O2 will drop quicker just because they don't have that bigger lung volume to pull in enough oxygen for their whole body. So when you are going through this, when they're doing the pulmonary function test, you are basically just there to help them do the test. Okay, this is something that's usually done by respiratory. This isn't something that the nurses do. Okay. The spirometer, this is something that we use post-surgery. Everybody should have seen the spirometer at some point. If not, I'll put a picture of one up. And basically what you're doing is you're practicing expanding those lungs. Okay, so if you have someone who's had a surgery, when's the best time to teach them how to use the spirometer? Before surgery. Okay, so many times in the hospital setting, we put that order in and they don't get it done until after surgery. The person's hurting. Yes, most of the time if you have family in there, they're going to help encourage. But some of you may have to then go in and encourage them, every hour to do their spirometer to help open up those lungs. What are we trying to reduce the risk of? Pneumonia, right.
RT is supposed to go in there and check on them too, right?
They do go in and check on them, but they're not going to come in and do it with them every hour. No, that's going to be part of your responsibility to encourage them to make sure they're doing it. Yeah. Quiz. What is the PFT? Pulmonary function test, posterior face test, possible facts test, or possible faking test? Got a little delirious. I was thinking I could use the other. Pulmonary function test. Good job. Pulmonary function test. Okay. Again, this tells us what is our capacity in our lung volume. Radiology. So chest X-rays, CT, MRIs. Okay. Ventilation perfusion scan. So chest X-rays, CTs, MRIs. Those are your most common ones. Okay. When they go down, main thing is as a nurse, you got to make sure that they don't have any metal on if they're getting an X-ray. Make sure they're not pregnant. If they're having a CT done, you need to check their allergies. Okay, because if they're having a contrasted CT, if they have an allergy to iodine, or if they have decreased renal function, then they cannot have the contrast done. You want to make sure they stay hydrated before and after to help reduce that contrast concentration within their system. You're going to explain to them that they're going to feel warmed and flushed when the contrast goes in. Okay, and radiology techs actually are the ones who place the contrast. So, and they can start IVs. Most of them can start IVs if they're IV certified. So they'll be the ones if they don't have an IV. If you're going into this outpatient and you're getting a contrast CT, then your RT person, or your radiology tech, will be the one doing that. MRIs. The main thing with this again is make sure they don't have any metal in their body because it's a big magnet. Okay, and you're at risk of that metal being pulled out. Also, you need to talk to them about if it's a closed MRI, about being claustrophobic. If they have claustrophobia, maybe talk about doing an Ativan, a Xanax before, Valium, something with their physician. If it's an outpatient, inpatient, talk to your physician. Hey, they're going down for an MRI, and they were just talking about they don't want tight, small spaces, and we don't have an open MRI. So then you want to maybe medicate them 30 minutes, 45 minutes before they go down, so it's working when they get there. Okay.
That's one of the questions.
Yes, because we have a form. Yeah, we have a form you usually have to fill out for a CT or an MRI that goes down to radiology, and that's kind of one of the questions you get asked. So I know last semester we talked about different oxygen devices, so I'm not going to go over them now, but I did put kind of just a neat little visual graph table of the different types of masks we did talk about, along with BiPAP, CPAP. I didn't add ventilators because you will go over ventilators in level 2. Okay, in level 1, as a potential LPN, you will never touch a ventilator. Okay, that is not in your scope of practice at all. Okay, you may have people on BiPAPs or CPAP, but usually if you need them placed back on, respiratory will come back in and then replace the mask and set the settings. But as far as like high flow, non-rebreathers, venturi mask, simple mask, nasal cannula, those are things you will manage and maintain along with respiratory. Okay. True or false? A non-rebreather mask can have oxygen running at 6 liters per minute. If you remember those lows. Non-rebreather masks can have oxygen running at 6 liters per minute. False. Anybody remember what a non-rebreather is? 10 to 15. Yep. You put a non-rebreather on someone and put them at 6 liters. What's going to happen to their O2 saturation? Let's see. Okay. So 10 to 15 on a non-rebreather mask. Okay. Those are things that are important to know because as a nursing student, you may have to be in there helping, resuscitate somebody or somebody with a shortness of breath, and they hand you a non-rebreather, you're putting it on there, they say, turn the oxygen on. It's okay to ask, what do you want it at? But you should know it needs to be between 10 to 15, okay? As an LPN, you're in a code situation, you get them back breathing, they put a non-rebreather on them, but you need to know that it needs to be between 10 to 15. Ooh, people are changing here. Chest tubes. Okay. We're going to just quickly touch on this because we're going to,
There.
hey, my little ghost in here. Keep acting up. You're going to go over chest tubes this afternoon with Shanessa. Okay. So the rest that I have in here about chest tubes, I'll probably do just a little voiceover with it. So that way you have it. You also have, I have several videos that I put up about chest tubes, pulmonary disorders, things like that. They're not required for you to watch, but you know, if you're having a difficult time understanding a concept that we went over, or maybe we didn't touch on it real deeply, those things I'm putting on there is to help you better understand them. Okay. Because there's no way possible in the 3 hours that I have you, especially like say I did an hour and a half, that I can go over every single thing that potentially could be tested on the NCLEX. Okay, so this is where you have to put in a little work yourself. Okay, I try to lay out the most important things I feel that are important for you, but the rest you have to kind of do on your own. Okay, so chest tubes are basically just there to help with pleural drainage. Okay, so we've got either trauma to the chest, we've got a pneumothorax, we've got atelectasis. There's several different things. The reason you could place a chest tube. We just need to either get the excess air out of that space or the fluid that's there, blood or whatever fluid. Okay. So you're going to talk about those this afternoon in lab. I know she put up some videos. You have a worksheet that's going to go over it. Okay. And so let me see if you can answer this. Why would a chest tube be placed? To drain blood fluid, air from the chest, to reinflate a collapsed lung, to help reduce an enlarged heart, or to add sterile water to the chest cavity. There you go. To drain blood, fluid, or air from the chest cavity. Yes, eventually that lung will be reinflated, hopefully, but that's not the purpose of the chest tube. The chest tube is to remove what's there so the lung can reinflate. Okay. Good job. I think there's one more. Pleural drainage. We're going to talk about the systems. Let's see if you know this. What does it mean? Oh, you may not know this because we didn't talk about it. Best guess. Excessive bubbling and the water still cube. We're supposed to have a little bit of bubbling. And if we have excessive bubbling, why would we have excessive bubbling? Ooh, so the chest tube, if it's obstructed, you're not going to see any bubbling. Okay, if it's clamped or obstructed, you're not going to see any bubbling. Okay, because remember, removing air, so we should see a little bit of bubbling. And when it's first placed, you're going to see a lot of bubbling until the air kind of balances out. Okay, but after that, if you have a lot after that initial placement, if you have a lot of bubbling, it means there's a leak in your system somewhere in the hose. Good job, guys. Oh, one more. What would be your order of assessment for a respiratory system in a child? Think about a kid. If you're having to assess them, what are you going to do first, second, third, and fourth? So we're going to observe first, right? Auscultate, because we want to, before we get on crying by touching and pushing, right? We want to listen first, palpate, and then percuss. Okay, so think about a kid. First, you want to look, auscultate before you get them mad, and then palpate and percuss could probably be either or, okay? But you want to do your minimally invasive to most invasive. Always remember on a kid, okay?
So the last two you could do either or.
Pretty much, yeah. Oh, I had lots of questions this time. The nurse has a patient with a chest tube. If the chest tube drainage system is accidentally disconnected, what should the nurse do? Apply an occlusive dressing and notify the physician. Place the end of the chest tube in a container of sterile saline. Secure the chest tube with tape. Clamp the chest tube immediately. Give on it. Place the chest tube in a container of sterile water. And it's because when you put that tube in there, it's not going to pull air in. It'll kind of stop the suction of air into the pleural space. We don't want to do an occlusive dressing because we still have the chest tube in place. It's just been disconnected. Okay. We don't want to clamp it because we still need it to drain if it's going to potentially drain, and we don't know how long the physician is going to be there. We don't want buildup of fluid still coming out. And then securing it with tape is not really going to do much. Okay. So it has to be sterile water. So usually in most places, if you have a chest tube in a patient, you're going to have a bottle of sterile water sitting at the bedside, unopened. And it's for that reason there. If it gets disconnected from the tubing, you're going to then put that sterile water up onto the actual tube and hold it in place. Let's see. What is the significance of bubbling in the water fill chamber? It's abnormal. It's normal if the patient's receiving mechanical ventilation. It indicates air leak. It indicates lung expansion. Bubbling or what? It indicates an air leak. So if you have constant, I should have put constant. Constant bubbling, it's going to indicate an air leak. Slight bubbling off and on is normal as the air is coming out of the lung space or the pleural space. But if it's constant, then it could be an air leak. One more. An example of subjective data is decreased range of motion. Left knee has been swollen and hot for the past 3 days. Crepitation in the left knee joint, so it's like creaks and cracks when I move it. Arthritis. Subjective. Because subjective, they're telling you it's been swollen and red for 3 days, right? I can see if there's decreased range of motion. I can feel if there's cracking, if there or hear it when they move their knee. And if they have arthritis, it's usually documented in their chart, okay? Or like with me, I have arthritic knuckles. So you can see my arthritis, okay? So that's subjective. Okay, let's see who made it all the way. Good job, good job. Okay, so I want you guys back at 1:15 then, since I'll give you an hour for lunch. I'll let Janessa know, and we will see y'all back, and we will
be here or in the lab.
Come in here first. Yeah, because we'll do groups into the skills lab. Is this PowerPoint gonna be? Yes, I will because I'm recording it, so I will upload this Kahoot that we just did. And I will upload the PowerPoint that I used for this.